Today we are going to discuss women coming in labor pain. After shaking the hand of the patient and introducing yourself, you start to take the information about the patient name, the age, the nationality, the social status, if she has pregnancy before, and also if she wasn't using medical contraception, and what is her blood group, and what is the RH typing, what is her occupations, what of this, she's smoking, alcohol intake, addicts on, if she's smoking or not, how many cigarettes she's smoking per day, and for how many years she's smoking. And the complaint of the patient has frequent colic labor pain, and we ask about the last menstrual date, and then calculate the gestational age of the patient, and calculate the expected date of delivery, and the onset of labor pain when, and the character of the pain. Colic lower abdomen pain. Colic starts in the upper abdomen and radiates down to the lower limbs and back. Colic abdomen pain and colic abdomen pain and radiates to the back, and the frequency of these contractions every how many minutes and lasts for how many seconds. Any vaginal discharge of mucus tinged with blood, or passage of clear liquor, or passage of clear liquor since several hours, or passage of deep meconium or yellow straw color or blood discharge. And what is the last meal, and when it is, for how many hours this last meal, and any medication she was using before coming to the hospital, as because some of those patients may go to dispensary in order to try the labor pain. We ask about any complications during the pregnancy, diabetes, hypertension, antepartum hemorrhage, preterm labor, and past obstetric history, when date of the pregnancy, and how many weeks it lasts, and any problem during pregnancy, and it ends in abortion or delivery. If it ends in delivery, what is the method of delivery, if it was a newborn male or female, and how many kilos, and any postpartum complications, and any neonatal complications, and the breastfeeding for how many. On some of this, then we start to examine the patients. We should determine the general condition, temperature, blood pressure, and there's bladder or not, and neck, thyroid or breasts, and there's leg edema or not. And then we do abdominal examinations, abdominal enlargements, the surgical scars or not, there's edema of the abdominal wall or not, and the fetal movement can be detected or not, hernia orifice, and then we palpate for only superficial mass, any tenderness, and the uterine contractions, the frequency of the uterine contractions, how many contractions every how many minutes, and it lasts for how many seconds, and there's fetal movement detected or not, and then run the fundal height, and we determine the fundal grip, this is head or buttocks or empty, and then the lateral grip, define where the back of the fetus or the limb of the fetus, and the first pelvic grip, the head is floating or it starts to enter, and second pelvic grip, and we auscultate the fetal heart sound, how many, and there is variability, or there is any deceleration. Then we are going to do the vaginal examination, inspection any vaginal discharge, blood or meconium, and digital examination to determine normal or edematous vagina, and we assess the pelvic outlet, pubic angle is wide or narrow, and the pelvic inlet if the head is not engaged to determine that the pelvic is capacious or borderline or second degree pelvic compression. And we assess the cervical position, it is anterior or posterior or central, and the consistency of the cervix is soft or firm, and the effacement of the cervix is not effaced or 20% effaced, 40% effaced, 60% effaced, 80% or fully effaced, and the rotation for how many centimeters, 2 centimeters, 3 or 4, 6, 7, 8, 10 or fully dilated. Then we assess that the membrane is intact or ruptured, and if it is ruptured it is glycol or it is yellow stain or deep meconium or bloody glycol. And we assess the fetal presentation, it is cephalic or breech or cord prolapse or face or brow, shoulder, and we assess the positions, it is left anterior, occipital anterior, sacroanterior, transverse or posterior on the left side or the side. And when we determine the station, it is -3 or -2 or -0 or engaged at the cervical spine or +1 or +2. And then we assess the progress of labor by examining the patient every 2 hours to assess the frequency of uterine contractions and the duration of the uterine contractions and the fetal heart sounds. And the cervical effacement, dilatation of the cervix to assess the progress, and the cervical consistency, and the membranes is still intact or ruptured, and the color of rupture, color of liquid is ruptured, the fetal presentation, the fetal positions, and the station, and the cabot or molding, the cervical cabot of disease cabot or molding, usually we record all the data of the patient on the partogram. This is the fetal heart sound, this is the cervical dilatation, this is the descent of the presenting part. Any medication is given, we should record this is in the partogram. This is the normal progress of labor. This is pulse and blood pressure. We may notice that the patient may have progressive cervical dilatation and then becomes low, and if it cuts the alert line we should take care. If it cuts the action line we should take a decision. If there is cephalopelvic disproportion we should search for cesarean section. If no cephalopelvic disproportion and the membrane is intact, we rupture the membrane at first, and if the uterine contraction is still not adequate we can give oxytocin to stimulate the uterine contraction. This figure is called primary arrest. Sometimes the patient progress up to 8 centimeters and then become slowly dilated or not dilated. This is second arrest, so this may be problem of the outlet or cord around the neck or inadequate uterine contraction. If there is no any fetal problems and no marked pelvic outlet contractions, or we can stimulate the uterine contraction if it is not adequate, if there is progress. And sometimes in malpositions of the fetus is deep transverse arrest, we can help the delivery by ventouse, and as long as there is no fetal problem. And thanks.